speaking of the immuno-oncology, let's transition to that, because I don't know about you guys, but I'll predict that this 2018 is going to be the year, that we get one approved for our patients, and we'll be using them pretty soon. And I think it'll be a sea change, truthfully, in triple-negative breast cancer. Let's hope I'm right on that. Let's hope. But maybe we'll start with maybe Claudine. Why don't you just summarize the single agent data that we have so far with the checkpoint inhibitors in the metastatic setting, and then we can maybe brainstorm a little bit about, are there any biomarkers we can look for in the clinic to help us?
So we've seen a couple of presentations this year, one at ASCO and then one at San Antonio, looking at Pembro. So the Keynote 086 trial that had two different cohorts, one in first-line metastatic triple negative, and one in second line or beyond. And in the first-line one, the objective response rate was about 23%. So that was a pretty reasonable as single agent objective response rate. It was far lower in the patients who had received prior pretreatment. So it was around 10% or so in terms of objective response rate. So that's with the single agent Pembro. So again, showing us, I think, a trend that we've seen in other trials as well, like in the durvalumab olaparib trial, it was also a much higher response rate earlier on with the immunotherapy. In the Atezo trial, again, there was a similar response rate. It was also in the first line setting, and that showed an objective response rate of around 25-26%. So again, getting the signal that in about a quarter of patients, we're seeing benefits just with single agent therapy in the first line setting in particular, and then looks like diminishing response as you go further along.
It's of note to me on that when they show you the spider plots and you see how long these people are going out. There's a subset of them that are getting out there. They're getting out there a couple years, which we hardly ever see. In the metastatic setting. So it's really it really is interesting. And those that have the CR or PR for Atezo or for Pembro in the first line setting have a really superior survival compared to those who progress or have stable disease. So definitely, like I said, signals there for sure. And neither are approved for the metastatic population, but given the data, some of us are trying to get insurance coverage. If we cannot, there are access programs that we can utilize to get these agents for our patients, and I for one am doing some of that, in selected patients. But then the question is, in what patients?
Exactly. How do you select them? Because that's a bit disheartening, as you said. So in the first line Pembro study, those patients were enriched for PD-L1 expression. When you looked in the later lines where there was no enrichment, and they compared responses to PD-L1 positive or PD-L1 negative, there was no difference, and it was single digit, I think 4 or 5% response.
So PD-L1 is
that's not feeling like a good biomarker to help select our patients. And I know you could probably speak to TILs as another possibility. I think we're all looking for how to best select these patients, besides just trying to use it early on and really trying to understand the optimal sequencing as well. I think your IMMU-132 data is really interesting to think that maybe whatever you use afterwards might potentially now have a primed tumor to respond better. So I think challenging to pick those patients.
Yeah, and the TIL information, as far as I understand it, and jump in here, is that we do know for HER2 positive and for triple negative in the preoperative setting, very nice data that the higher level of TIL, and there is an international consensus about how to read the stromal TIL, and it's with every 10% increase in the percentage of stromal TIL, you'll get an improvement in disease-free survival in the early stage setting, but we're not using that obviously in the preoperative setting, and that was as a predictor for benefit from chemotherapy and from HER2-based therapy. In the metastatic setting, in the single agent trials, there have been biopsies, of course, of metastatic lesions, going back and looking at those archival tissues and measuring the TIL, as per the standard methodology that has been published many times, especially by Shireen Loy, who's really been the leader in this. And interestingly, not very interesting, showing that there's a difference in the percentage of TIL depending on your metastatic site. So it's the parenchymal lung and the lymph nodes that have the highest percentage of TIL, and like the chest wall is pretty devoid, liver bone, not much at all, which is interesting because in the original Rita Nanda trial, with the 18% response in heavily pretreated triple-negative patients with pembrolizumab, there was a small percentage of patients that went out about 2 years or so. And if you say, what's the phenotype? Who are those patients? It's the Isikoff patients. It's the parenchymal lung, lymph node, and breast.
We're coining a few things
Yes,
here
I
today.
know.
The Isikoff patients.
And
Steve
it's all coming together. You know, the same ones that are very responsive to the DNA damaging agents are the same ones that are really, hyper, much more sensitive to the checkpoint inhibitors, which is a terrific lead, in terms of how do you further this. But so the thing is, though, we can't really be asking our pathologists to tell us about the percentage of TIL, even though the methodology is published and has been standardized. It's still something that the College of American Pathologists have not picked up, or ASCO hasn't picked up as one of our biomarkers, such that there's really been standardization around the country and such. So it's not something, I don't think, that's really practical for us right now in terms of a selection criteria. I think it comes down more than anything to phenotype and using it as early as possible as we can in the metastatic setting.